So this is a chronic disease update on COPD, and it's a session that's an update to support your revalidations and just keeping your knowledge up to date. And so it's only aimed at those already reviewing and managing COPD patients. If you're not already managing COPD patients, you may need to go back and do some further training and updates. So today the session's being run by myself. My name's Sarah Partridge. I'm a clinical pharmacist by background, and I work 1 day a week for the training hub. What I'm doing so I am a prescriber, and I run clinics regularly reviewing COPD and asthma patients. So that's like a little bit of my background. So we've got a few ground rules. Feel free to participate, ask and answer. I am by no means a specialist, and so this is kind of a peer, I'm kind of piloting it, but it's a peer-to-peer update. So everyone's contribution is welcome. So in other words, I may not know the answer to the questions, in which case, hopefully someone in the room, because you're hopefully all managing COPD patients, so hopefully someone out there will know the answer, or there might be multiple answers. It's important that we listen to each other, we respect, and from a Zoom, well, we're not using Zoom, but from a Teams etiquette, feel free to eat and drink during the session, because I understand it probably is your lunch hour, and we're going to record the session so your colleagues who can't attend can see the updates. So hopefully it'll be a good summary and overview. So the aims of the session today is to kind of refresh, it was mine and hopefully your knowledge with regards to COPD, particularly with regards to any recent national or international or local practice changes, to reflect if any of this information means that you need to make a change into practice. And also it's who else is here? Actually, I know that person, they're in the practice down the road. Is it worth kind of thinking, actually, can I build a network with other like-minded primary care clinicians? So, for example, for respiratory, Gemma Bird, who was one of our nurse associates that works at NATH, she actually has a respiratory kind of community of practice. So actually, if you please do contact the hub to find any more information, but if that's something that you might find useful, feel free. So it'd be good to get kind of a feel of who's in the room. So I'm a pharmacist. Do we have any nurses today? I don't know if anyone wants to write in the chat or unmute. Do we have any ACPs? Do we have any?
Oh, sorry. My name's Eve. I'm a nurse practitioner in the community on the acute home visiting service. So I see patients supposedly for acute on the day episodes of ill health. So we come across a lot of COPD patients in the area that we cover.
Brilliant. And actually, maybe we can come to you about some hints and tips of managing the acute conditions at the end. That might be really good.
My background is respiratory nursing before I did this, but I'm a bit out of date, hence why I've come back on, I've come onto this.
Brilliant, but so welcome. And yeah, acute, we might have to come to you. You might be able to answer better than me or anyone else in the room. Anyone else want to unmute? So it's really good to have Eve there. So I believe we've got some nurses, got some ACPs. There was a GP booked on there. So yeah, feel free. Look who's in the room. Is there anyone that you can build a network with? Can we answer questions? So I'll move on to the updates. So first things first, you should always go to the national guidance. So the NICE COPD guidance hasn't been updated since July 2019, so I've pretty much ignored that. So then the next big guidance that's out there is the Gold Report in 2023, and that's had actually multiple updates. So we're going to come a bit more into that. So let me just move the slide on. So the first bit, the Gold Report changed a bit, was to do with the taxonomy and how COPD caused. And so they've now produced a table, which you'll find in the Gold 2023 guidance, classifying the different types of COPD. And this is based on 2 recent papers. One is by Selly from 2020 and one is by Stoltz. And the reason why they're trying to classify the COPD is to make you think more about the causes. Me as a practitioner, when I automatically think COPD, I think of environmental causes. So you think of the cigarettes, exposure to household pollution or occupational hazards, things like that. However, there are a vast range of other causes. So if they're young, I would consider potentially antitrypsin deficiency, but thinking wider than that, if they've had childhood asthma, they may be at risk of COPD because they may have had like repeated infections and caused damage. Again, that's the same with infection-related COPD. It could be that their lungs weren't quite developed due to early life events such as premature birth, and so their lung function isn't quite as normal. So this is kind of a useful way to think, okay, have I thought about all the potential causes? So in other words, think wider. So COPD is now a term to emphasize the kind of persistent and progressive airflow obstruction, and it might not be due to environmental causes. However, yeah, it should be noted that whatever the cause, whatever the definition, it's always the same with a post-bronchodilator forced expiratory volume of less than or equal to as 0.7. So that's still diagnosis, still the same spirometry, but the causes, think wider, and things like that. There's also a new kind of definition of diagnosis to recognise this wider criteria of identification and diagnoses. So just kind of be aware of that. The next change is there's also included a bit of information on CTs. So I don't know, has anyone here managed any long-term COPD and referred for a CT or anything? So personally, I have when I've suspected bronchiectasis. So that patient was lots of recurrent chest infections and coughing up a lot of sputum. So I'm thinking like egg cups full. And their symptoms weren't quite matching like the picture that I was seeing in front of them. So that was a person that I referred for a CT to rule that out. But yeah, the gold document also says, think if their symptoms don't match their severity, if they're in the severe category, and you think the FEV1 is less than 45% predicted, and there seems to be other symptoms, it might be that you do a CT because then they could be considered for some of the surgical options that we now have. So that's kind of things to think about. There's also in the Gold report some recognition of the importance of identifying exacerbations and trying to prevent them, because actually you're more likely to increase the quality of a patient's life if you're kind of trying to prevent those exacerbations, because if you're having those frequent infections and things like that, you lose lung function. If that's increasing your risk of mortality, and it also, if your lungs are struggling and more damage, you're then going to be increasing your risk of further infections and things. So yeah, that's another little bit of an update in Gold 2023. Moving on to probably the bread and butter, they haven't really changed the other important aspects. So pulmonary rehab, stopping smoking, making sure they've been offered vaccinations, and those are all kind of still very key. Self-management plans, rescue packs, so they're all really significant and still in the Gold 2023 guidelines. The main area of change is within pharmacological management, with the Gold 2023 reporting kind of recognising that triple therapy can reduce mortality and exacerbations, particularly in that patient group that have moderate to very severe COPD. So it used to be, I don't know if you all remember Gold 2023, but it used to be A, B, C, D, depending on their MRC score, their CAT score, and their exacerbations. They've now changed the ABCD to ABE, and they've merged, in other words, the group C and D. So looking at that, what does it mean in practice? So it means that there should be very few patients that are just on a LABA or a LAMA. So unless you've got someone with really minimal symptoms and less than one exacerbation per year. So those one person on Braltus or Spiriva, if they're still getting symptoms, we probably should be shifting them to a LABA and a LAMA that's on the formulary. Other things to be noted, an ICS should only be used with triple therapy. And generally those that have kind of asthmatic features, but it also recognises that eosinophils could be quite a useful measure, with 300 being the number. However, I go to the next slide, the threshold for the ICS is lowered. So yeah, if they're having frequent exacerbations, they should be on LABA-LAMAs, and if there's asthmatic features or raised blood eosinophils, then consider the ICS and assessing if it's adding any value. If they're not exacerbating and they're symptomatic, then again, we should also be using a LABA-LAMA of a choice that's in the formulary. I'm not going to make any inferences there. So this is a bit more of an extension. So whether they are you kind of ignore the ABE once you've started the first set of treatment and when you're reviewing it. So it depends on what their response. So again, before you change any treatment, check adherence, or there's any possible comorbidities going across. So is there any evidence of heart failure? Is there any like anxiety that may be making the symptoms worse? But yes, COPD and asthma reviews, they need inhaler technique checking. So we shouldn't really be doing them routinely on the phone because it's such a key part, which I think most people are doing. It should be face to face. And then what you choose to then do depends on the main symptom presented. So if it's shortness of breath and they're only a LABA or a LAMA, then consider a change to a combined product. If they're still symptomatic, then check their inhaler technique, check their comorbidities, check adherence. And then if they're still symptomatic, consider kind of changing the device, because it might be they might get on better and get more of the kind of drug delivered by using a different method. Implement or escalate non-pharmacological treatment. So have they stopped smoking? Have they tried, is there MRC 2 or more? Can they go to pulmonary rehab? Would they engage with that? So think bigger and beyond the pharmacological treatments. If they're repeatedly getting exacerbations, then have a look at the eosinophils, switch to a LABA-LAMA, add in an ICS, and refer as well. This is all kind of mirrored in the local guidance, which I'll come to. If they're still symptomatic and they're getting exacerbations, that might be when you might refer to secondary care, because they might want to consider roflumilast or azithromycin. Both are AMBER 2, so they will need recommendations for a specialist. So just out of interest, because I think I've come across one roflumilast. So that is a phosphodiesterase 4 inhibitor, which affects the kind of non-steroid anti-inflammatory pathway. So it's important to know, because you'll get letters saying patients started on roflumilast and they might come into your clinics where you're reviewing. And kind of the most common adverse reactions associated with it include diarrhea, weight loss, nausea, abdominal pain, headache. And then I'm not sure if you're aware, but roflumilast is subject to additional monitoring for weight loss. So if they're coming to see you in clinic, check their weight, which we should be doing for COPD anyway, because we should be thinking, oh, weight loss, must scores, things like that. Are they getting good enough nutrition? Important as well to know, if underweight, then it's critical, it's recommended anyway, that they always have their weight checked at every healthcare professional exposure. And interestingly, if they weigh less than 60 kilos, they should have a risk benefit assessment done, because they're at higher risk of sleep disorders. So that was my roflumilast learning. Azithromycin, I didn't realise until like not that long ago that it's ineffective if they're smokers. So if they've started smoking and they're on it, then you might need to flag that up and let the starting prescriber know, or depending on who's managing it. The other thing to be aware of with azithromycin is hearing loss. So, and if we catch that early enough, it may be reversible. So it's important to think that and ask any relevant questions. So COPD, there may be other medicines like this that might appear on the medicines. It's not necessarily just inhalers. So kind of just having that awareness. So azithromycin, think hearing loss, and roflumilast, think weight loss. And then what about those already on LABA ICS? So I know in practice, probably about a third of patients are on Foster or equivalent, a LABA ICS. And the reading around, if they're stable and response is adequate, and you're not fancying trying, they've had quite a lot of exacerbations and it's worked to maintain that, then it's probably worth staying on the ICS LABA. If they are exacerbating, no matter what the eosinophils are, then it would be worth stepping up to triple therapy. And if not exacerbating, but still has like breathing symptoms, then safely step down to LABA-LAMA, because not all COPD patients will benefit from the ICS, and actually be exposing them to the risks of having these steroids. So think, oh, actually, it stopped them exacerbating, it's working and their symptoms are well controlled, I'll keep them. Oh no, they're still getting exacerbations, I'll put them on triple therapy and see if they improve. Or if they're not exacerbating, kind of think step down. But remember, co-diagnosis with asthma and COPD, as you've probably seen, is quite common, in which case they should be on an ICS. So just be careful in any of those asthmatic patients, as you probably already do. Just going to touch on local guidance. So that was last updated in April 2021, with the review due in April 2024. So things will look to change the beginning of next financial year. It mirrors kind of a lot of what was in Gold 23. So if someone's symptomatic, then using a LAMA-LABA. And consider starting an ICS, so triple therapy, particularly if they have repeated exacerbations, requiring multiple steroids, potentially consider, but definitely worth a try if they have asthmatic features or steroid responsiveness. So that might be told by the eosinophil count, or you might want to send the patient out with some peak flows to see if there's any kind of variation and things like that. But yeah, it should always be, if you're offering it, check the guidance, and then document your reason for it. So I would write high eosinophils, discuss choice, we'll try ICS. And then make sure that they get a follow-up, because if it doesn't make any difference, then it might be that we want to step down. So review in this case is really important. So that's just a touch there. Local guidance update. So how I created, I probably should have told you this at the beginning, but how I created these slides was I went out to secondary care, I went out to the ICS, pulmonary rehab and the Stop Smoking Clinic and asked them for their updates. So that's where the chosen things are taken from. So particularly strongly echoed by a number of people was reinforcing about rescue packs. There is really good evidence that rescue packs are really beneficial to patients. They reduce hospital admissions, they reduce the seriousness potentially of the exacerbations and the damage that that might cause. It helps the nurses that are going out and running the acute clinics. However, any use of rescue packs must have a clear self-management plan, and when issuing them, checking with the patients, do they understand how to use it? And there is some clear not saying PC guidance out there. What often patients fall down on is that they're meant to contact their GP surgery or COPD specialist nurse, or it can be the pink card if they're starting their exacerbation rescue packs. You do come across patients that just start it, manage it them on their own, and then they just request the next pack. Actually, it's just they should still seek medical advice. It just stops that delay. And actually, if they're not contacting someone, are they the right people to be having the rescue packs? If they have 2 or more exacerbations in 12 months, they should be getting a review, which is why generally rescue packs shouldn't be on repeat medicines unless there's a really strict protocol or procedure. So we should be thinking, are they true exacerbations? Could it be a differential diagnosis, for example, bronchiectasis? Do we then need some sputum samples to check what kind of bacteria they're growing? If their symptoms are worsening, is it malignancy? Do we need a chest x-ray? Do we need a CT? Have they started smoking again? Do we need to encourage them to give up? Also thinking fracture risk. And if they're having 3 or more steroid rescue packs, then according to the local guidelines, we should also be thinking osteoporosis risk, and this should be documented in the notes. So we need to use FRAX to assess fracture risk, and then we might be needing to send for bone density scans. We'll go with that. Can't say that word. Note, it says 3 or more in the thing, but it also comes with the caveat, more sooner if other risk factors are present. So are they on any other medicines that might increase that risk? Have they had previous fractures? Things like that. But you can always refer to FRAX and the local guidelines if need be in that area. And then if you want to, if this is an area, so if you're a prescriber, ideally you should be auditing your own prescribing, something within your own prescribing once a year. It might be you want to use as a really good resource called How to Resource for COPD. I can send these slides out, that's fine, and that link will work. And that's based from Target and the Royal College GP resources. So if you've got any questions or want to look at the evidence behind rescue packs, then that's a really, really good resource. Bit of a note on formulary choices. So there's the main one, I think, is the first choice kind of ICF. It's not, but one of the first choice changes that saves quite a bit of money for MDIs is a switch from Foster to Lufrabec. It's the same ingredients, same excipients, same, everything's the same. So as long as the patient is aware then of a switch, it should be quite agreeable to them. The only thing to note that I thought when looking at the picture was the 200 6 strength is a green. So when you've got a patient going on, oh, I'm on my green inhaler, it might not be so clear cut. Because patients love just calling them blue inhalers, pink inhalers. Well, this steroid LABA inhaler is green. There's one that's pink and one that's green. So just kind of being aware of that. Another one out there is a tiotropium to Tiogiva, but ideally we shouldn't be using a lot of LAMA on its own. So you may be switching to LAMA-LABAs depending on the patient's symptoms. These come as refill packs and one with the device. So it's a bit more environmentally friendly potentially, but you just need to be careful of making sure that they get the right issues at the right time. But hopefully we won't be using much of that, but just be aware that's the most cost-effective brand at the moment. The easy one is the Foster to Lufrabec, but at the same time that doesn't comply with the greener inhaler agenda, so which is another consideration that we've got to worry about. So there's a lot on NOTS APC, there's a lot of greener NHS resources. So they've got a minimising the environmental impact of inhaler prescribing protocol, particularly with regards to salbutamol. There's an information for healthcare clinicians, so the 4 steps of greener healthcare. There's a patient leaflet that potentially some of my colleagues have inserted the link or put it as a PDF on some Accurix messages and sent to patients. So if you're considering switching and you know they're coming in advance, you can say, right, how do you feel about the environment and switching to a dry powder? But the key to any of this is an inhaler is only worth switching if a patient is going to take it. The biggest damage to any environment is a non-used inhaler. So actually, I always feel the first line is to optimize, and then if they can use both, then go for the greener choice. So that would be my key message. So just to be there on there. So yeah, lots of resources out there, and that's kind of an agenda that's going to be driven, I think, continuously now. So just have that in your back of your mind. Other useful resources. So I came across mylungsmylife.org. I don't know if you've come across this resource. The reason I picked this one out is they've got MDI and turbo inhaler videos in a whole range of languages, including Urdu, Mandarin, Polish. So hopefully responding to our local community, you'll be able to use those videos, and they've got loads of, so if you go to the website and you click on the lady, I have COPD, there are loads and loads of really patient-friendly resources on things like exercise and diet and things like that. So it's a really useful website that I would recommend. And the other thing is be aware of the local support groups out there. So I don't know if anyone's routinely referring people to the Breathe Easy groups. So there's one, the Nottingham City one, they meet in like West Bridgeford area on the first Wednesday of every month. But there's also one in Mansfield and Ashfield. So just find out where your local ones are. Because actually COPD can be quite hard, particularly if they're in the moderate to severe end. And they might need some support from some other people out there, and that might be a good place to go. If you don't know, you might have a social prescriber attached to your practice, and they might be aware of what support is out there. So then I was just going to open it up to the floor. So they're the main updates that people have told me about. Any questions, really? I might not be able to answer it, but hopefully someone in the room will be able to. Is it the same inhaler pathway, bronchiectasis, and emphysema, I think it's very, very similar. I think they might use some of the antibiotics and things, but I think there is a local guidance and support. They might also use carbamazepine a bit more and try and reduce the secretions. Anyone else got anything? Has anyone recently managed anyone with bronchiectasis and wants to unmute and talk?
Can I just point out, I don't know if it's still the same, but we see patients on acute home visits for bronchiectasis management, and they need 2 weeks of antibiotics rather than 1. That's still the case.
I think so. Yeah. I think it's very patient specific, but yeah, they often need longer courses because, of course, for simple COPD, it's 5 days, but those with more complicated history often need longer courses. You are totally right, but that should come from the specialists initially saying we recommend these patients have longer courses, but make sure that's documented somewhere so that it's always referred back to.
And that's the problem, is we see lots of patients who have prescriptions issued via telephone consults from GP practices. So that sometimes gets missed, and they're just having 5 days, which isn't enough. So it's just something to highlight, really.
Perfect. That's really good, really useful. Thank you so much for that. Anyone else? Jessica's writing in the chat. I hope that's been useful. Is it longer steroids course as well? sometimes I think that is, it would normally be in the clear plan. The other thing to think about is repeated courses of steroids. If they're having repeated courses, they might be building up, they might then need a taper if they're getting repeated doses, they might then need a taper if they keep having to need them, because then you can't then suddenly stop them abruptly if they've got used to it. Where can I refer my patients to for sputum clearance techniques? Does anyone know if they don't fit into the pulmonary rehab pathway? Ooh. It might be worth contacting pulmonary rehab because they might take them potentially.
It depends where you live as well, who you're registered with GP wise, because I know Nottingham West have got their own respiratory physiotherapist linked to their pulmonary rehab service who can do home visits. So it just depends where you are.
Yeah, it might be worth just asking locally, and there's quite a few physios now attached to practices and things, so it might be that they might be able to support or talk to your local PR, because sometimes if they're symptomatics and they might benefit, they might take them as a referral because you've got a clear need there. Have you got anything else that you see from the acute side that would be worth general practice knowing about?
I think that my concern is still, we don't see it that often. I cover mid-Notts, so I cover kind of Ashfield, Mansfield area, and we do see recurrent prescribing on the phone, which I know it happens. You know, that's the kind of health service we're in a bit more now post-COVID than we used to be, but I do get a bit concerned sometimes when I do see patients that have had multiple courses of antibiotics and multiple reissuing of rescue packs without anybody actually casting their eye over them. And like you said, they're the ones that you worry about because they're just taking them regularly without any kind of knowledge of the risks with that. So yeah, that's one, not bugbear I have, but it's an ongoing problem really.
Yeah, so we need to be thinking more about it, not just automatically issuing it, because patients see it, I would think, as a wonder medicine, because they take their steroid and they suddenly feel way better. So they go, oh yeah, and don't actually fully appreciate what that means.
And then I'll go in and say, I'm not giving you any more because you have got an acute exacerbation, and they're not very happy. Well, my doctor does it. Well, I'm not doing it. So it can cause, joking aside, it can actually cause just a difficult consultation then when you are going in to do that face-to-face visit, and the patient's expectation is, oh well, I'm going to have this replenished, because the penny's finally dropped within a practice, and they finally realise that this person's had 12 courses of amoxicillin in a year. So it can be a problem for us out visiting patients in their own homes.
Brilliant. So it should be sensibly done and with clear processes of review, because it works really well when used appropriately, but it's an emergency pack for a reason. So it should be in that last resort emergency. And what did Emma put? This may be a silly question, but other than keeping well and being controlled with the best way to reduce exacerbations, want to make sure that I'm missing the thing. No, making sure, stopping smoking. The ones with the best evidence is pulmonary rehab if their symptoms are severe enough to get an MRC of 2 or more, and then stopping smoking, and then trying to prevent through infections. If they've got severe COPD and young, it might be worth getting specialist opinion, because there is more and more surgical interventions, but refer to the local pathways and the local guidance for that. That's beyond my scope, but they are doing more and more like bullous surgery where they remove part of the lung. So if you've got someone that's severe, then that might be an option, particularly if you've got more of a younger severe patient. But if you've got a fit, like someone which is active, then again, age is no barrier. But yes, refer to secondary care if you can't control them and their symptoms are worse, because there are more options than there used to be. Let's put it that way. Yeah, brilliant. The British Lung Plan.
It's really, really helpful resource online for patients.
Any other resources that people have come across? So I would use the Right Breathe and the Asthma and Lung videos as standard videos. Anyone else use anything else that would be useful to share? Otherwise, that's my update in a nutshell. I hope it's been kind of useful. Is anyone going to make any changes to practice based on what's said? If you could write in the chat, that would be amazing. So Emma uses the Right Breathe app, but for inhaler technique videos. Yeah, I quite like Right Breathe. But yeah, it is recorded, so if you arrived late, it should be on Teams. Jessica, that's great. Eve will be happy. So we all have to work together because these are a group of patients that are always going to be COPD patients. So whether they're not being seen acutely to start with, they might be later on. So we need to get those messages correct from the beginning. Yeah, that was really useful information about the pulmonary rehab in Nottingham West. The thing is as well, if you use services like that and they in one area and they go really well, then the chances are they'll increase them elsewhere. Yes, that's true, Emma. But if it goes well, then hopefully that will be recognised and moved elsewhere. Because the things being piloted.
They've got to be completely housebound though and not be able to get out, because it's Karen, what's her name? Karen, can't remember. I used to cover that patch when I was a respiratory nurse, but I can't remember her name because I have the menopause and I can't remember it. Oh, it's so annoying. Thompson, Karen Thompson. There you go. Who's the lead physio for the respiratory service, for the pulmonary rehab and the respiratory physio for that team in Nottingham West. Karen Thompson.
And the main thing with pulmonary rehab is it's not a one-off necessarily. If they found it beneficial, you can refer them again. So they can do it more than once. So normally I would leave a minimum of a 2-year gap. But yeah, you don't have to. If they've been once and they engaged, they can go again. Because things change with COPD, it does get worse potentially. So yeah. Well, thank you all. We've got some Dawnay is writing something else. Thanks, Emma, for coming. But yeah, the next update in September will be immunisation. And then it will be hypertension in October, followed by asthma in November. So just some dates to look out for in your diary. But yeah, it's kind of just a quick update to support you being current. Brilliant. Thank you ever so much. Enjoy the rest of your day and go and eat some lunch.